known as spongious bone. And because of its properties and its structure done of trabeculars and bone marrow can be expanded. Oh, I know. A lot of you, like me, have heard or read these numerous publications saying that if you place an implant and if you try to expand the bone, then you will end it by necrosis. And I should say, this is true. This is true if we're talking about a cylindrical implant. Try to place a cylindrical screw in a piece of wood. First, you need to drill. And then you place your cylindrical screw. But you place it till the drilling stops. If you force it, what happens? And this is physical. You break the wood, ending by losing screw. Now, I want to place a self-tapered screw in this piece of wood. First, I don't need to drill. Well, of course, depending on the density of this bone. Let's think about bone, of this wood. I'm mistaking myself. But I place my tapered screw and then take a screwdriver, applying a high torque. And then the screw is going in without any drill. I don't know if some of you are doing homework, but you know why these self-tapered screws have a stop. Actually, they have a flattened head just to stop the screw. If they don't have these diverted head, then they go all the way in. And actually, if you refer to implantology, this is more or less in this biomechanical aspect what we can do. Expanding the bone. You can expand this trabecular bone, both in diameter, in width, and in length. Of course, you all the time need to take care of the cortical layer. But like this, you can place an implant, expand this cancellous bone, and taking care of this cortical layer. Here, you have facing two different techniques. Because we know that it's not a new thing. There are different tools that can permit this bone expansion. Who was the first one? Summers. Summers himself that proposed these osteotomes. But we have these bone expanders. And you have here, we should say, the more classical, and using these expanders in flapping your sides. And here, using a drill and using the expanders, flatness. The main thing here, the critical issue here, is that if you're flapping, we know that because of the weakness of this cortical, when you try to expand, and if you try to expand this cortical layer, you will end up by a fracture, what we call a Greenwood fracture. Well known, well described. This is what happened here. And this was presented as a model in this kind of procedure. But what happened here? They wanted to expand the bone because the ridge was thin, and in expanding the bone, placing the implant without grafting. Okay, this is smart. But if you're flapping, what do you think what happened of this? bone resorption. Why that? Exactly. In raising this flap, you don't have the blood supply. If you don't have the blood supply in the cortical layer, you will end up by bone resorption. What happened here? And this is why I face these two head-to-head, these two techniques. Flap and flapless. Because, of course, you need to know exactly the volume of the bone, where you're drilling. But what happened? Even if you leave the same amount of cortical, but because you're flapless, because you still have your blood supply, then you have big chances of avoiding this bone resorption, right? And you know what? This I have in my clinic. I have a cone beam since 4 years. Nowadays, cone beams are very familiar. You'll find a lot of cone beams in different surgical units in different practices. And now, it appears to us, because we're doing more and more of these three-dimensional radiographies, we think that we have more bone resorption. Because all these bone resorption we are discovering today, we had them since a long time. But we didn't know this. If you are, like me, an old implantologist, try on your old patients to make 3D radiographies, cone beam, and you'll be surprised of how many implant surgery you did and how many of them are facing bone resorption. You'll be surprised. Because on a 2D radiography, mesiodista is perfect. And why we have so many periimplantitis now? Because of that. Well, get back to the topic, atrophy. Of course, atrophy can be considering a full region, lateral maxillary, or the lower mandible, lateral mandible. But we can consider the loss of a tooth, loss of different teeth, individually, like an atrophy. This is an alveolar atrophy, and this has been as well commented that we can gain bone, for example, in this kind of situation, in the first molar, within the expansion of the septum between the three sockets. And this was, by the way, this is live surgery, and this is on cadaver. The same to explain the technique as extraction, and within the septum, expanding the cancellous bone in the middle. The big problem, and I put this slide because it's an old case, and at that time, we didn't have so many options in the choice of the healing cap, and this is the healing cap. Nowadays, there are different implant systems that allow you the choice of both diameter and the height of your healing screw. And now, and probably a lot of you guys are doing two-step in one, just one surgery, placing the implant and placing the healing cap at the same time. But the main issue here is the right choice of the healing cap, ending by, it was a Summers technique, so sinus lift within the crest. Second point is the choice